C-sections could be done for many different reasons. And so this is the type of C-section where literally the moment that it's called, we are pushing back to the OR. It has to be done now. Not, okay, our baby is not tolerating labor, let's get it done in 30 minutes. We're talking about a true crash scenario, okay, where you are. Deb Dawson used to be our labor and delivery manager, used to say, your hair's on fire. You're running around like your hair's on fire. Okay, so let's just talk about some situations that would require an emergency cesarean. Prolapse cord.
Great.
Uterine rupture?
Yeah, absolutely. Okay, so you have maybe a toe lap going on, all of a sudden there's loss of fetal station, loss of the heartbeat, mom's in severe pain. Okay, what else?
Prolonged decel.
Prolonged decel, good. You've got a category 3 strip. Okay. I'll probably back to a category 3 strip. Now, is minimal variability a bad thing? What if I said it was minimal variability with recurrent leaks? That's a bad thing.
Yeah.
The minimal variability by itself could be a fetal sleep pattern, could be a lot of things. Okay. What about like placenta previa with hemorrhage? Okay. What about placental abruption, heavy bleeding in a category 3 strip? So lots of reasons. Sometimes we don't know what the problem is. The baby is just not happy. Okay. There's so many reasons, guys. We could probably name 1,000 more scenarios, but you get the picture. Something bad's happening. Okay. So let's just start with the scenario. Actually, let's not start with the scenario. Let's talk a little bit more. So how do we get the patient ready for an emergency cesarean? Let's just go through like a little mental checklist. What's the first thing we should do, similar to a shoulder dystocia, when we identify the need for an emergency? Call for help. Yep. So who do we want to call?
Our pediatrician.
Pediatrician.
House soup and tell them to call.
House soup. Yes. Yep. And you know that's a fantastic resource. I've never had that before. I don't know if that's a unique Ivinson thing.
That's like a rural hospital thing. It's awesome.
So I've never had that before. Usually it was called a charge nurse or something. We don't have that here. So call the house supervisor, which is kind of like your charge nurse really, and tell them we have an emergency cesarean, get me a team, I need a pediatrician, anesthesia, and get me an obstetrician. You know, maybe I'm not even here, right? Maybe you've identified that something bad is happening, okay? And probably before you would do that, you would probably call the obstetrician and say what's going on. I would say, get him to the OR now, I'm on my way. Okay, okay, so we call for help. What else do we need?
You need to tell the mom exactly what's happening.
Good, communicate with your patient, wonderful, okay? Pretend this patient's in triage. They just walked in holding their umbilical cord. Said, this just happened. My water broke and this happened. What is this?
Yes.
Get an IV, yeah, okay. Where should you put it? What size?
A big and a better.
AC, yeah.
14.
Do it like yeah. Do it like the ER. Just quick access. Don't even worry about anything else. We can move it later. Okay, good. What else? Yep, get some fluids going.
Antibiotics, probably.
Get some antibiotics going.
What do we have in the labor cart?
We have all of the antibiotics that both providers prefer.
Yep. Because we have a whole emergency C-section kit in there, right?
LR, we've got like all of it in there.
Awesome.
So I know because I just spent the last 4 nights checking all the labor cards.
Good.
Good, okay. If you have time, if they need a shave, you can do that. Get them switched to a gown and then physically get them into the OR. Okay. Other things I think are important. So now you're in the OR. Let's say that labor and delivery is really busy and house soup's called in an OR team for you. Make sure that we are trying to sign off to that OR team, so at least get a brief like, hey, this is Samantha Harriet, it's her second baby, she prolapsed the cord, Dr. Westbrook's on her way in for a stat section. Even if that's the most you can give them, that's the most you know. And I think the OR team has complained a little bit. Take this with a grain of salt, because I know this is two-sided, but sometimes I feel like they show up and then the labor team disappears really quickly. So try to stay for transition of care. That's really important, especially in emergency. If you don't know what to do, look around and see who's not paired up. And a lot of times the person who gets forgotten is anesthesia, okay? So if you've got a CRNA or an anesthesiologist by themselves trying to put a patient under, that is extremely difficult to pull up all the drugs and do the intubation unassisted. And we had that scenario probably 5 or 6 months ago. And Dr. Dugas was asking for help, but nobody acknowledged him. He was not being aggressive enough, and he admitted that later that he should have said, you help me. So what we decided in this first class, is that maybe the person who's the baby catcher should assist anesthesia, because you don't got anything to do, well, you do not have anything to do at the moment until that baby's here, so assist if you can.
But check your warmer
Yeah.
first and
Yeah.
make sure your stuff is good to go.
Chances are, even if you help anesthesia get the tube in, you still have a few minutes before I get the baby out, so
Yes.
it's not gonna be long. If you are the person that's opening, I don't care, just pull it open and get me a scalpel. Something that, we'll show you the Betadine prep too that every patient should have for an emergency. We do not wanna be prepping with chlorhexidine or the Dura prep, both have a 3-minute dry time. And if you proceed without that drying, then you have a fire hazard, and we're pumping oxygen into this patient, so we do not want a fire hazard. So we'll show you the Betadines that are back there, and there's a stat C-section bucket kit, there's a disposable scalpel in there so that we don't have to try to load a blade. I can't even do that effectively, I never do it. So just this, yeah, everyone's
Yeah.
already nervous, so just get the table open, get the patient prepped with Betadine, we'll go over how to do that, and hand whoever your surgeon is a disposable scalpel and just let them go, they don't need anything else. They might need a retractor, they might need a couple sponges, maybe suction, but for the most part, you can get down to baby with just a scalpel.
And they'll be very clear about what they need if they
Yeah.
don't have somebody who they know is a scrub tech, or if something
Yeah,
like if it's
chances are, if it's
one
a
of you
true
guys.
emergency, and if Debbie's not there, Danielle's not there, somebody who's not used to scrubbing, it's gonna be kind of chaotic. But the most important thing is the prep, the drape, and a scalpel. After that, we can all breathe once the baby's out and figure out what we're doing. Okay, take a moment to settle down. Okay? So I think that the clear thing too, if you are so you were the patient's nurse, right? So in the OR, what I would say is to continue with that lead, okay, and be like, Katie, baby catching, you are gonna assist anesthesia too, okay? Or you hook up the suction in the Bovie, you know, just kind of tell your team what to do, because in an emergency situation, people need guidance and direction. Okay?
And if you are in there and you don't have a role, find a role, because chances
Yeah.
are somebody does need your help and you're nervous or you're scared, but somebody else probably also needs your help.
Yeah.
So just check your surroundings.
So, and once you get into the OR, get the patient onto the OR table, get the other bed out of the room. These are simple things that can be done. And someone, please, always stay with the patient so we don't have a patient fall. I've never had that happen, but it makes me so nervous if I ever look in that room and no one's with the patient. But again, it's making sure the surgeon's got what they need, the anesthesia's got what they need, get the baby warmer set up, your suction, your TPs, your intubation stuff, you've got everything you need, baby drugs. Yeah. Questions about emergency cesarean and how to kind of proceed with that? Okay.
So let's talk about a cord prolapse a little
Okay.
bit, and then I'll show the video.
Who wants to describe cord prolapse?
Cord prolapse is when after the water is broken, the cord slips out between the baby's head and,
The
down
cervix?
to the, yeah,
Yeah.
down to the vagina.
Okay, yeah. What happens when that, tell me what's going on that makes it an emergency?
Baby can't get oxygen in there.
Because,
That happens because it gets sandwiched between the head and.
so every time the uterus contracts, it's forcing the fetal head down, it's pinching off the umbilical cord, which is baby's life supply at that point, okay? What do you typically see on the monitor? Okay, that's fair. Anybody?
Or plates.
Probably not lates. What are lates a sign of?
Oh, something.
And if you're having,
Variables.
yeah, because you're having cord compression,
You
right?
see cord compression.
You would see deep variables, and sometimes sometimes the variables just go down and come back up, but when you see them go down and do this, that's complete cord occlusion and then back up. So that's, if it's a bad cord prolapse, you'll see it shoulder, you'll see it drop dramatically, and then you'll see it ride flat at maybe 50, maybe 40, and then it'll rebound. And then after a while, the baby just gets really upset, and then you might end up with prolongs, okay? So if you're laboring a patient and they start having variables, what should you do? Check them, yeah. Do you know what the umbilical cord feels like? It's a pulsatile, soft, ropey structure. And if you feel that, yeah, call for help right away. Okay, so let's say you're in the patient room, your patient, Dr. Harriet was in there, broke her water, an hour later your patient starts having variables. Maybe they start out as mild and all of a sudden they're big. As a nurse, go into that room immediately and check that patient. What do you do if you feel the cord?
Push the head up.
Should you take your hand out and call me?
No.
No.
Take your hand up.
Okay. So for the new nurses, someone who's had to do this before, Okay, tell us what you did.
Well, a nurse came out, it's a prolapse cord, she was like
But she came
whispering
out.
it. She
Yeah.
came out and said, there's a prolapse cord, the doctor was in there, the doctor
Okay.
ruptured.
Okay,
And
prolapse the cord.
And so the doctor was in there,
Okay, good, so no one left the patient, good.
and I'm like, did you just say prolapse cord?
Yeah.
And she's like, yeah. I'm like, so don't do that.
Yeah.
Go out there and say, I need help, you know,
Yeah.
because I barely heard her.
Yeah, and remember I told her a
And-
shoulder dystocia, oh my god, get the stool, we gotta, no, we have a shoulder dystocia, we have a prolapse cord, pull the emergency cord up, put the call, I don't really like the call buttons, we don't always acknowledge it, right?
Yeah, I don't love the call light either, especially
Yeah.
if like, I was thinking about like at night, if we've got 3 people and 2 people are gone, like.
Yeah,
who
I
would
would,
call
I
them?
would pull the
So,
cord out of the wall, yeah,
Mhm.
pull the emergency light, whatever that is, like the thing that the patient hits in the bathroom when they pass out, or usually it's their kid and they're playing around. Hit that, cause everyone comes running.
And if you end up being wrong about an emergency, that's
Thank
fine.
goodness.
Like, don't be scared to pull it because you think people will think you're silly or like you don't know what you're talking about.
Mhm.
It's like chances are you're probably right, so
Yeah.
pull it.
And I've seen that happen, I was like, I'll never do that again.
Yeah, so
Or
don't-
so I'm like, I stick my head in and the doctor said prolapse cord and then I shouted out. And then I put on sterile gloves and the doctor and I
Switch.
replaced our hands.
Yeah.
And I was in that position and I stayed on the patient's bed.
Yep.
Until we
Until the
went to
baby's delivered.
till the baby is delivered. And my finger, be careful too, my finger was like this. And it hurt for
Yeah.
a few months.
Yeah.
I bet.
But, so what you're telling them is great, so you're actually pushing, you're not just in there like trying to prevent it from going any further, you're pushing it up. Guys, this is like the same as you're trying to push the baby out for me if I've got an impacted head in the pelvis and we're doing a C-section. It is a forceful effort. And you may also be feeling the umbilical cord at the same time, just because it's right next to you. And so if you're feeling it, if it's doing this, maybe you're communicating to the doctor, hey, the heartbeat's low, we need to go, or you need to push up more. Or if you're feeling this, so the last cord prolapse I had, Susan was telling me, we've got a good heartbeat, because she can feel because we're rolling down the hall, we don't have a monitor on anymore, so I can feel the cord, it's got a good heartbeat.
And we did get to relax when we got to the OR and we checked the baby's heart rate. It was a good heart rate, so we slowed down.
Yeah, yeah.
And we were okay.
Yeah, and you can take the time to crowd control. You're still gonna go fast, it's not a, let me get a cup of coffee or anything like that, but, that's actually really helpful information.
That was the only one I ever had.
Wow.
But it's like you never forget.
Yeah, I
You
had
never
3 in the
forget.
last year.
Can you always like feel the cord, or is it just kind of like?
If you can't feel the cord, you could have the cord occlusion somewhere else, or be getting cord compression somewhere else. But also an umbilical cord prolapse is cord compression. And so you could have a baby that has the cord pinched maybe between its knee, or it's wrapped around the neck, and every time it contracts, it's tightening up. It's not that it's strangling the baby that's making the heart rate dip, it's that the cord is occluding. And that's returning to blood flow to the baby. I mean, it actually is problematic, can actually strangle them, I don't mean that it can't, but really what's happening. So it's just cord occlusion, but it's due to the location of the cord, and it's not going to go away. You can't roll the mom, you can't put her in a position, whereas with other variables, we try position changes, right? Try to get the baby off the cord. You can't do it this one. Can you put the umbilical cord back?
You should not.
No, never. Funny situation in residency is, I don't remember who the resident was now, this was before my time, walked out of the room, said to Dr. Kingsbury, there was an umbilical cord prolapse, but it's okay, because I put it back. And he looked at the resident and he said, nothing about what you said is just okay. Get her to the OR now. So that was a story that kind of lived, but it's okay, because I put it back. Yes, no, you cannot replace it. Breech deliveries are high risk because of cord prolapse, because you got the little feet down there, right? The feet are like this big. Do you think they plug up that hole? No, the fetal head does that. That's why we hate, well, there's plenty of reasons to hate breech deliveries, but that's a big one. Okay. Okay, so get her to the OR, move her to the table, make sure everybody's been buddied up and being helped. Clear communication, even if it's a quick SBAR, situation background assessment recommendations with the other team that's coming in. I think, yeah, we just go practice. You feel good about that? Anything
Yeah.
we missed?
Nope.